Okay, so this is my signature assignment. I chose the case study on insulin overdose. All right, so the case is that you're a senior anesthesia resident. You've been working an on-call shift over 24 hours long, about 27 and a half hours straight. It's 3 in the morning. You get a call after you've just got out of a long surgery about a patient, Mr. H, who's a 70-year-old male, admitted to the cardiac ICU the night before for an active MI. Now he has symptoms that's leading the surgical staff to believe that he has ischemic bowel, and although his vital signs are stable now and he's vented, his kidney function's declining. You notify your attending of a high risk but warranted surgical exploration surgery that you would do for ischemic bowel. The team prepares after discussing the situation, different possibilities, worst case scenarios you might encounter with it. Um, and then you begin the surgery. Once the surgery is underway, you confirm your diagnosis. However, he is losing a lot of blood. You guys have to start some packed red blood cells, and at that time, some labs are drawn. The labs alert the team to poor kidney function. He has a high creatinine and a high potassium as well. Due to his condition, his body isn't going to be able to get rid of the extra potassium on its own, so you guys have to intervene. The case study doesn't mention exactly what interventions otherwise are going on, but there are some. And the attending also asks you to deliver 10 units of insulin for the patients. You grab the vial, you grab a 10 cc syringe, you fill it up and inject the entire thing into the patient. This would be 1,000 units or 100 times the dose that you were asked to administer, which was only the 10 units of insulin. Um, what went wrong here? I mean, a few things. Number one, you're fatigued. Although you've been on call for the last over 24 hours, you've been working a lot of it, and the last hours before the surgery, you were in another high risk or a long surgery, and you're going straight into another one. This surgery is high risk and would have been something difficult for someone who actually got a full night's sleep or rest. The insulin. Was it the kind of insulin that they should keep in the OR? I mean, not necessarily. It's the subcutaneous insulin, not diluted, and it's 100 units per milliliter. You'd have to definitely dilute that to be able to push that in somebody IV wise. Communication. Was there really good communication? Could the attending maybe have mentioned to you or asked you, how are you planning on administering that insulin? Maybe you could have said, I have a question about this insulin. Maybe before the surgery even started, you could have mentioned you just got out of another long surgery, and at this time you're really fatigued. Maybe you should be observing the surgery and not participating in it. All of those are different things that sort of went wrong in the case study. I also did a little bit of research and I found an article that was called Key Vulnerabilities in the Surgical Environment. It's from March of 2016, and it talks about surgical procedures have a high medication error rate and adverse drug events because it's a high risk area, and often you're doing things under high stress. There's a high error rate, like I said. Um, Out of all the medication errors, it says that 80% of them are deemed preventable, and more than one-third of them lead to actual patient harm, with the remaining two-thirds having the potential to cause harm to the patient. Um, a lot of the errors that they mention have to do with absent or incorrect labeling, wrong doses, failure to act, omitted doses, wrong medications. Some less frequent errors that are in the OR were inadvertent boluses, remaining in the tubing, wrong timing of medications. In this case, obviously, it was a wrong dose of a medication that you administered before realizing it. Resolution rules. Um, you're going to have to admit and take responsibility for the error that was made. like you do in this case study. You have to let your attending know, I administered 100 times the necessary dose of insulin to the patient. The patient is then going to need close monitoring. The nurses in the cardiac ICU are going to really have to monitor his insulin closely, which they did. You're going to have to speak to the family. The attending, if necessary, he's going to have to take disciplinary action, against you if that's necessary, or with you. Um, I'm sorry. Solution and barriers. So, again, back to that article that I was talking about, key vulnerabilities in the surgical environment. They mentioned that we need to establish an environment that promotes reporting, learning, interdisciplinary respect, cooperation, and promotes teamwork and safety. So, as I'm writing right here, all members of the healthcare team need to feel comfortable enough they can communicate their concerns, whether that includes questions on common drugs, their administration, or otherwise. The attending needs to be able to feel comfortable that he can give you a reminder. Yeah, it might be something that's common sense. The attending also knows that you are fatigued, that everyone might be fatigued. At this time, if you felt fatigued, not comfortable to be in this surgery, and maybe just observing this time, you should be able to communicate that too. Or if you just needed a reminder in this surgery about something, again, you should feel comfortable and able to do so, and not have fear that you'll be ostracized if you mention something like that. Medication preparation and packaging. Like I said, maybe the insulin in the vial isn't the best insulin to have in the OR because it will need to be diluted. Maybe they need to employ a barcode scanning system that will help identify the medications before preparing and administering them. Um, Maybe you can limit your hours in surgery. So you just went from one long surgery into another surgery. Maybe the acuity of the surgeries. Maybe they really need to monitor what surgeries you're doing in a row as a resident. Yes, they can limit your hours, but it also makes a difference how long you're in each surgery. And like I said, the acuity of them. Barriers to this might include cost effectiveness, fear, like I said. Maybe you were too scared because the environment wasn't the environment that I described, where everyone felt comfortable. There was teamwork going on there, and felt like maybe they're gonna make fun of me, or felt scared to mention it. In time, all of these can be barriers. I mean, it takes time and costs money to employ different systems at the hospital with medications, even if it is just pre and diluting medications and otherwise. And these are the references that I use. Obviously, I use the case study a lot, and the article I was talking about, key vulnerabilities of the surgical environment.